Every day, millions of Americans put their health and ultimately their lives in the hands of their physicians. But you should know that the sanctity of the doctor-patient relationship is being threatened by insurers and others looking to increase their profits. Physicians take an oath to do no harm, but they, perhaps even your own doctor, are under increasing pressure to think of treatment costs first and patient health second. Some insurance companies even remove doctors from their HMO network if they don't follow the insurance company's cost-cutting guidelines. Doctors are in a very difficult position. In Michigan and across the country, insurance companies and others are engaging in practices that put profits before patients. Some are offering cash and other incentives for doctors to prescribe certain cheaper medications over others that may be more effective. This practice is called therapeutic switching.
In some instances, incentives may be genuinely value-based. We should permit incentives for selected preventive services and positive health behaviors. However, in other instances, programs may be focused on cost savings without sufficient attention to clinical concerns.
There is nothing wrong with prescribing generic drugs and saving money. The problem arises when doctors are offered financial incentives to switch a patient's medications to reduce costs, even when the cheaper drug may not be as effective. In early 2007, Blue Care Network paid 2,400 Michigan doctors $100 for each patient switched from a brand-name statin to a generic cholesterol-lowering statin. The Blue Cross Blue Shield of Michigan-owned HMO is no longer offering this incentive. But over 3 months, it paid doctors a total of about $2 million, saving the insurer $5 million, according to news reports.
If somebody's paying me just to switch a drug from a branded product to a generic use, it just puts money in my pocket. It doesn't really help patients. So I think we need to look at paid performance that is not based just in economics, but it should be really based on something that delivers a better outcome to patients. Because that's why we all are here.
The impact of therapeutic switching may be much broader, contributing to health disparities that result in minority populations being sicker than whites. That is a problem for everyone, because it adds to overall health care costs, which we all end up paying.
There is much that we do not know about the effects and possible unintended consequences of incentive programs. For example, we think that incentives for higher use of generic medications will lower drug plan costs in the short run. However, we also know that switching medications can lead to lower rates of compliance and persistence with medications. Further, therapeutic substitution, not just switching from a generic version of one drug to the same drug, but switching one drug for a different drug within the class, can have a host of unintended consequences. Short-run cost savings can lead to long-run health and cost problems.
Therapeutic switching can mean big savings for insurance companies. Cutting costs at the expense of patient health without the patient's knowledge has real health risks, and not just at the pharmacy counter. Insurance companies are offering incentives to reduce the number of diagnostic tests, such as MRIs.
Let me give you an example. If you came to see me and you were having the worst headache of your life, I would be expected to do an MRI because it could be an aneurysm. But if I roll the dice and say, well, statistically this isn't an aneurysm, I may get away with it. But if there was an aneurysm and you went home and it burst and you died, how can I face your family? Because I try to save the insurance company, for which you're paying, by the way.
When cost drives policy, health is not the first concern, and it should be. We believe that incentives to influence prescribing practices should be banned, and that patients should know when their insurer has pressed for changes in their treatment.
If there's a practice of providing incentives to those who are writing the prescriptions, of giving them an incentive for writing a certain prescription, shouldn't I, the patient, be advised of that before I decide to switch from my brand to a generic?
A gift is almost never a gift. When you provide incentives to people, even if they're minor, it does generally affect their behavior.
Physicians don't like cost-driven switching because it goes against good medical practice and could destabilize the trusted doctor-patient relationship.
As a physician, I am constantly reminded by insurance companies to keep costs down. While I can appreciate the insurer's concern regarding keeping costs down, I don't like the methods and how they go about it. I get anywhere between 8 to 12 requests for change of medicines every day. Telling a physician that he or she will be given a bonus for coming in under cost is not a good idea. If a physician monitors his or her cost to the insurance company with the purpose of getting that bonus, then to whom is he loyal?
Legislative interest in this issue continues to build. Banning prescription incentives, be they from insurers, drug companies, or others, is just one aspect of the fight for quality health care. Patient groups say we must also make sure treatments aren't restricted to only certain patients and that patients know about financial arrangements offered by insurers. The list goes on, and different groups will raise their own issues as this battle for quality health care grows. That is why we are asking you to join the Michigan Alliance for Patient-Centered Care. Together, we can ensure that patients, not profits, are at the center of healthcare decisions.